up. But we are recording this initial part of the meeting, which is the presentation part. And then we will switch to doing Q&A. And when we do that, we will turn off the recording because we want this to be a time where you feel that you can ask what you really want to ask us, and we'll be better able to protect your privacy that way. And so we ask that you, as participants, please hold this as a confidential space, and also as participants recognize that we as healthcare providers can't protect the confidentiality because there are lots of people here. You can change your screen name on Zoom if you want, to not have your full first and last name on there. You can post things in the chat along the way if you want, and we can kind of take some questions in the middle, but then we'll have a lot of Q&A then at the end after we stop recording. And at that point, depending on how many people we have, probably it'll be fine to just unmute yourself and ask questions if you'd like. With that, let's go ahead and get started. I'm very delighted to have our guests today, Dr. Rebecca Shelby from Duke, Dr. Juliann Stalls, a postdoctoral fellow at Duke, and Lisa Massa, who is a physical therapist, right, at Duke as well. So I'm doing okay on the intros, but I'm going to let them give you a lot more detail about what they do and their program, which is really nationally renowned. So, all right, with that, I'm going to turn it over to our guests, maybe, if I can get the slides to advance. Not going anywhere. Let's see. Okay, woohoo, got it.
Okay. Hello, everyone. I'm Lisa Massa, and as Crystal mentioned, I'm a physical therapist at Duke Health. I have worked at women's health for the last 25 years, I think. So I'm excited to be with you here today. And I'm going to get us started with discussing what we call the hot flash dance, the genitourinary changes and challenges, rather, of menopause. I do want to just make a couple of quick announcements. During this presentation, we may use the word woman, and we do recognize that some individuals may choose other words to describe themselves. We are speaking to all people who are presently experiencing or who may experience menopause symptoms. We also recognize that some research articles we cite specifically focus on heterosexual intimacy, but the interventions that we are suggesting today would be applicable to individuals who align with different sexual orientations. We also advocate that future research to be inclusive of all sexual gender minorities. If you could go to the next slide, that would be lovely. Okay, so I thought this might be a fun slide to start off with because I think most people in this group probably recognize this as a picture from a famous movie in the 80s called Flashdance, where this actress, Jennifer Beals, plays a character, Alex, who's a welder by day, dancer by night, hoping to get into an elite dancing school. And in one of her many dance routines at the end, when she sits in the chair, water pours down all over her body. Well, point of fact, Jennifer Beals is now 61 years old, and my guess is if she has water pooling all over her body, it's probably more due to a hot flash than trying to get into an elite dancing school. But I just thought that might be a timely image for the folks with us today. So we can go on to the next slide. I'd like to start off by talking about the menopause transition. According to the British Medical Journal, in 2021, there are over 1 billion women and globally who are in menopause or in the menopause transition. So by no means are we alone or unique. We identify the menopause transition as the time of perimenopause and the first 12 months after your final menstrual period. Most individuals recognize that they are in the perimenopausal phase when they start to experience symptoms such as hot flashes, mood changes, impaired concentration, and impaired memory, sleep disturbances, fatigue, joint pain, reduced libido, and increased belly fat. The average age of menopause is 51. but 7% of women undergo menopause transition between ages 45 to 50, and 2% undergo the transition before the age of 40. Now, that is what those statistics are basically for what we consider a natural menopause. There is another type of menopause referred to as an iatrogenic menopause, and this is when a menopause occurs because you've had removal of ovaries by medical intervention for some medical condition, and therefore you cease to have sufficient ovarian function to continue to have a menstrual cycle. For individuals who experience an iatrogenic menopause, oftentimes their symptoms are sudden and can be more intense. Next slide, please. So this is sort of how I sort of see the circle of life a little bit, in that we start on the left and we're feeling groovy and content, and then all of a sudden you can't get cool enough. And then a lot of women start to go through a phase where they feel chilled, and then suddenly they get to what I call the Goldilocks stage, where they feel just right. Um, the symptoms of natural menopause as we go through these phases can last from 3 to 11 years. And 20% of women experience hot flashes into their 50s, 10% into their 60s, and 55% into their 70s. So some people deal with this for a long time. There can be both racial and ethnic difference that impact your menopause transition experience. It's known that African American women often have more intense vasomotor symptoms like hot flashes. And then in some cultures where becoming an elder person in their group society is more revered, they actually are more at peace with the transition because it actually elevates the perception of who they are in their specific society. One of the things that's true for all individuals is we recognize that this is a natural process, but sometimes that also limits us from seeking any care to modify the symptoms we're having, thinking this is just something I have to deal with. Next slide, please. So for today's specific conversation, now that we've given an overview of menopause, we're really going to hone in on what myself, Rebecca, and Juliann and I can offer folks who are experiencing the very specific symptoms of genitourinary symptoms of menopause. And those symptoms are vaginal dryness, vaginal itching, which is sometimes known as being pruritic or pruritus. You may have seen that in a medical note. Experiencing decreased vaginal lubrication for physical intimacy, experiencing pain with sex, which is sometimes referred to as dyspareunia, and also a series of urinary symptoms, including urgency, dysuria, which is painful urination, and an increased frequency of UTIs. Now, while we're going to be focusing a lot on the sexual health aspects, we all recognize that oftentimes when women have these urinary issues, they also can significantly impact their sexual health and their desire to be sexually intimate if they're having issues with incontinence. One study that looked at over 1,600 women with GSM symptoms between the ages of 55 and 65 noted that over half of those women said that the symptoms negatively impacted their overall quality of life, and that it also specifically impacted their arousal, and that they had decreased arousal, decreased sexual satisfaction, and decreased capacity to reach orgasm. And sexual function for women who experience GSM it has been noted in survey research to be critically important, both to the woman individual self-esteem and as well as maintaining a good relationship with their partner. So we recognize that these symptoms are something that we should try to address and manage for all individuals so they can have better sexual health and overall quality of life satisfaction. Next slide, please. So I want to talk just for a quick minute about hormone replacement therapy. Unfortunately, neither Rebecca, Juliann, and myself are medical physicians, so we are by no means experts on HRT. We did want to just advocate that there are a variety of options available that you can discuss with either family medicine primary care physician, OBGYN, or discuss in a specific menopause health clinic. I know Duke Health has a specific clinic for menopause symptoms. I'm sure others in the area do as well. But what we want to do is encourage you to talk about the options. So if you're interested in hormone replacement therapy, I think it's important to see what your options are and not just listen to what friends have tried or commercials on TV or that sort of thing. And again, just to reiterate, it is a natural life process, but that doesn't mean we can't modify the effects that the symptoms of menopause are having on you. Next slide, please. So now we're going to get into the stuff that I love to talk about, which is the physical therapy interventions for GSM. And I would say, broadly speaking, there are four particular topics that I like to discuss with my perimenopause, menopausal patients. And they include a sexual health discussion, which is really just oftentimes beginning with making sure that my patients have a good understanding of sexual health education. And then moving into lubrication education, which we'll discuss in a subsequent slide. Pelvic floor interventions, specifically for the muscles and the tissue and skin that surrounds the openings to the vagina and rectum. And then what I call the big picture. So sex is not just your pelvic floor, it's an entire body experience. So how do your hips move? How does your back move? How does your partner move? These are all things that we'll talk about to make sure that people can maximize the sexual intimacy that they want to have with their partner or during an unpartnered activity. Next slide, please. So what is good sexual health? So I really love the World Health Organization's definition of sexual health. So I'd like to just take a minute and read it to folks to understand sort of the broad scope of sexual health. Sexual health is a state of physical, emotional, mental, and social well-being related to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. And for sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. So when I read that, I felt like we could kind of sum it up in four bullet points: was to know your values and what is right for you, to protect your body, to build positive relationships, and to maintain a sexual health routine that works for you. Next slide, please. So the three that I think physical therapy often can help with to achieve good sexual health is first to protect your body. One thing that we sometimes don't think about is STI, which is sexually transmitted infection education. Unfortunately, the biggest section of our society that is experiencing STI infections are women between the ages of 40 and 60 years old. And the reason for that, it is suggested, is because many women say, well, I can't have a baby, I don't need to use condoms or some type of barrier protection. But of course, as we know, barrier protections are the things that help us not get STIs. So just reminding folks who are sexually active or who are returning to being sexually active, perhaps after a period of inactivity, that we still need to think about barrier protection and barrier protection, excuse me. The other thing that we often ask about is, does something hurt when you engage in sexual activity? So ideally, a sexual experience should be comfortable and pleasurable. And if it's not, what's hurting and when does it hurt? And can we identify that pain is coming from a physical component of your body, whether it's a muscle, a joint, is skin or tissue dry, and how can we work on making those things function better so that you don't experience pain. I also think PTs can do a pretty good job in building positive relationships with yourself and your partner. So one of the big things I hear a lot about are comments and concerns or insecurities about body image. Things like, my thighs are a little bit more flabby and I just, I'm not as toned as I used to be, or I have a scar in a place that I didn't before and I really don't like taking off any more clothes than necessary to be intimate with my partner because I don't feel my body is as beautiful as maybe they want it to be or I want it to be. Sometimes my patients will talk about that my partner says when we're having physical penetrating intimacy that he can't feel my muscles contract as much as he used to. So that makes me feel more insecure about using my body. So I think in a myriad of different ways, I think PT can help with things that help address some of those issues. And then finally, maintaining a sexual health routine. Excuse me. And two examples would be the use of routine lubrication. And then I put the use of dilators, but I probably should have also included vibrators, other sex toys that help with arousal, anything that makes your sexual experience more comfortable and pleasurable for you and your partner. Next slide, please. So next we're going to segue into lubrication education. And the big component I'd like to share with everyone is I want everyone to feel comfortable knowing the difference between a vaginal moisturizer and a sexual lubricant. So vaginal moisturizers are non-hormonal treatments that help rehydrate the vaginal mucosa. They can be used daily, but sometimes they can be used just a couple times a week, depending on the severity of the dryness. And they are really focusing on addressing the vaginal dryness. I often use the analogy that for my patients who like to use a specific face cream at night to help with the wrinkles and keeping your face hydrated while you sleep, that there's also moisturizers you can use for your vagina to do the same thing. And oftentimes we recommend people use them at night when they're sleeping, because then that way they're not don't have to be concerned if they're concerned at all about messiness or anything like that. Sexual lubricants are specific for when you're choosing to engage in acts of sexual intimacy, and their goal is to decrease friction, which sometimes friction can be pleasurable and sometimes it can be downright uncomfortable, and we're looking to decrease that discomfort. And again, hopefully enhance pleasure. Now, I will say, I typically advocate for my patients if they're choosing a sexual lubricant and they have a history of vaginal dryness to select a lubricant that doesn't heat up or cool down because they're going to have different chemicals in it that can be irritating to your already sensitive vaginal tissues. There are a myriad of options out there, and I'm happy to discuss. We have lists of them, and I'm happy to share that with folks if they're interested. But sometimes it's a matter of you just got to try to see which one works best for you and your partner. But just to go to the next slide, please. I do want to get in a little bit more discussion about the type of lubricants. So with the lubricants out there, there's usually three things that they are based in, which is either water, oil, or silicone. Now, water-based lubricants are the easiest to clean from your skin or bed sheets or toys. And they found that water-based lubricants tend to cause less genital irritation than some silicone lubricants in women. Silicone lubricants are sometimes favored because they're thicker, a little bit more slippery, and they tend to last longer than water-based lube. One of the things that I know can be a challenge for some of my patients is you go ahead and you use your lubricants to start, but then if you have to stop or put on pause a little bit in the middle of your intimacy because you have to reapply lubricants. So some people prefer silicone because it lasts a little bit better. They also tend to recommend silicone-based lubricants for anal sex. They are also safe for most forms of barrier protection. However, and this is a key point, if you choose to use silicone sex toys or any items that are made of silicone as well, you do not want to use a silicone lubricant with a silicone toy because it tends to break down the outer surface of the toy faster. So that's just something to consider if that's part of your sexual health experience. And finally, your oil-based products are really like your petroleum-based products like Vaseline. And I typically don't recommend these because they tend to cause vaginal irritation and can increase the risk of vaginal infections. So my recommendation would be to always look for something that is water or silicone-based. Next slide, please. So you meet with your doctor, you talk about your perimenopause, menopausal symptoms. They're like, you know what, I think you could benefit from a physical therapy visit. And most people go, a physical therapist? What more are they going to do for this? Well, there is a specific group of physical therapists who focus in pelvic health uh, rehabilitation and or pelvic health physical therapy. Sometimes they're also referred to as women's health physical therapists. And they have specific training above and beyond their entry-level education to address issues of bowel, bladder, and sexual function. So I would encourage you, if you choose to seek out a physical therapy appointment, that you make it with someone who has that specific title or training. When you get to the actual first visit, here are some of the things that you can expect. The therapist will likely do a very thorough interview on that first day to talk not only about your sexual health, but your overall health. As many of you are probably aware, there are many health conditions and medications which can impact our sexual health. So having a good idea of what your overall health picture is helpful then to inform the specific issues regarding your sexual health and how we can best address them. I often joke that physical therapists are the biomechanical experts of sex, in that we want to make sure that everything can move the way it's supposed to when you're engaging in sexual activities. So we are trained to do what is considered a modified internal pelvic exam. No speculum, no tools of any kind, just a single glove finger inserted into the vagina to assess the muscles that create the wall of your vagina. We also assess the external tissues in the vulvar clitoral region to see if there's any if findings or concerns in that area. And then last but not least, we have to think outside of the local area. And if an individual has a history, particularly of hip or back issues, sometimes those issues can impact your ability to engage in sexual activity in the way that you want to. So based on all that information, the physical therapist will come up with the plan that creates with a combination of education, manual therapy, and exercise to address the specific issues that you may have when you go to visit them. Next slide.
Can I ask you a quick question here?
Yeah.
So a lot of our patients are reluctant to go to PT if they have a history of sexual trauma.
Mhm.
And so it's just something that comes up every single time we talk about PT. I don't know if y'all are planning to address that, but later, maybe so. And you can tell me to wait. But if not, I just wondered, kind of how you think about that, Lisa, in providing trauma-informed care.
Yeah. So great question. First of all, it's a great question. It brings up a good point I should emphasize. We always offer to do an external internal pelvic exam, but a patient always has the right to say no for whatever reason, including a trauma history. Interestingly enough, Juliann, Rebecca, and I think it's been 2 years ago now, created a sexual health educator class for physical therapists, which we trained 2 cohorts of PTs here at Duke, that basically talks about trauma-informed care and all the different aspects of how trauma can impact a person's presentation and their ability to engage in the intervention requests that we may have for them. And it's a 20-week long training that's built off of psychologically informed care with an understanding of the scope of how physical therapists can practice. So we take trauma-informed care pretty seriously, and we are able to demonstrate the efforts that we've made to be sensitive to that fairly large scope of people, because it could be medical trauma, childhood trauma, anything, right? But it's a great question.
Great. Yeah, I just also want to empower our participants here today to ask, like if you're referred to a PT and they're not at Duke, or maybe even if they are, to ask them if they've had this kind of training because it's so important in terms of helping people feel more comfortable. So thanks for answering that question.
Sure. Okay, so here are just some of the rehab interventions or approaches we may take. So once we've done the evaluation and gotten an idea of how your body is functioning, one of the things we'll be very interested in is the physical challenges that you have engaging in sexual activities. Is it secondary to pain or what we call limited range of motion? And this segues into the next piece, which can you attain the sexual position of your choice? So most of my patients who, especially if they've been in long-term relationships, they have their go-to positions that they love, right? And nothing is more frustrating when they can't get into that position because they've lost flexibility in their hips. Maybe their partner's had a back surgery and now they can't move the way they did, and they're being asked to compensate for the lack of agility in their partner. So these are some things we talk about because there's all types of wedges, pillows, straps, things we can suggest to help you be in a supported position, but still be hopefully attain the position of choice. And if that's absolutely not possible, look at other positions that would be acceptable to you and your partner. And then finally, with regards to pain, when does it occur? Is it during foreplay, penetrative sexual intercourse, or afterwards? Because that sometimes also tells us what what the pain generator might be. So these are all things that we may very well be talking about with our patients depending on their needs. Next slide. Okay, I just wanted to give a brief blurb about hot flashes and exercise because it seems like anytime I talk to folks in the perimenopausal, menopausal time of life, they say, well, exercise helps. So I just wanted to say that we often do recommend some exercises for our patients. Right now, the research is inconclusive that it always helps with hot flashes, but we do know that obesity is a trigger for hot flashes. So if you're exercising more and possibly losing a little weight, then indirectly it can be impactful in reducing the frequency of how often you experience a hot flash. Next slide. Okay, so in summing up, I really feel a multidisciplinary approach is best. I am a much better clinician by having clinicians I have around me helping me provide comprehensive sexual health care to my patients. So to the physicians and nurse practitioners and PAs who are all invested in this area, the psychologists like Juliann and Rebecca, who've been awesome colleagues for me for a long time, I think we all try to reinforce that sexual intimacy is a multifaceted experience, so different experts can address different aspects of it. And that I strongly want to encourage everyone that it's okay to seek the sex life you want to have. I think in American society, sometimes we feel like, well, I'm old, I shouldn't have sex anymore, I shouldn't enjoy it, or whatever. And I'm going to strongly discourage you from sending yourself those type of negative thoughts because I do think there are opportunities to have a positive sexual experience that's meaningful to you. Next slide. All right, and I'll hand it off to Juliann and Rebecca, who will discuss the psychological interventions for menopause.
Thanks, Lisa. Hi, everyone. My name is Juliann Stalls. I am a clinical psychologist here at Duke, and I'm really excited to have the opportunity to be with you all today. I do sex therapy counseling and do research in the area of supporting folks to manage sexual health concerns, particularly after cancer treatment. So I see a lot of women who have experienced iatrogenic menopause secondary to their cancer treatments. And I'm going to get us started today by jumping into talking a little bit about some psychological or psychosocial approaches to addressing concerns that might come up related to sexual health in the context of menopause. So just to kind of start at a high level, I'll start by giving an overview of some of the different types of intervention approaches that might be of interest to help manage symptoms and concerns that can arise related to sexual health during menopause. So individuals or couples might decide to pursue sex therapy counseling support, which is a type of psychotherapy or talk therapy that might help to address barriers that negatively impact sex and intimacy. So, for example, navigating, sexual changes that might have occurred during or after menopause. A couples therapy approach might be of particular interest and can be helpful to improve concerns such as, communication challenges that might come up around intimacy and sexual problems. A lot of individuals and couples struggle to talk about sex, so this is a really common experience and might even be something that is really beneficial to occur in the context of changes that might be happening, physically and emotionally secondary to menopause. As another example, psychoeducation is really another tool that psychologists or other mental health providers might be able to use to support individuals and couples to address sexual concerns after menopause. And this approach really focuses on increasing knowledge of sexual function and treatments that are available to address different sexual problems. So, in line with that, I'm actually going to transition us now to talk a bit about sexual function and treatments for different kinds of sexual problems. And we're going to do a little bit of myth busting together. Okay, so first myth, sex is easy for most people. So, yeah, next slide, please. This is absolutely not true. And in fact, we often say to people in some of our first meetings, sex can be complicated. And this is because there are so many different factors that can drive people's sexual experiences and their overall sexual health. So just to give some examples, we have some of these highlighted here, things like cultural and community beliefs. So an example of this might be like messages that people have received from their families, from their communities, that sex is shameful or that sex is only for certain people. I hear this sometimes with folks saying things like, sex is only for like the younger people, or that's kind of what society tells me. And then that can kind of play a role in their pursuit of and their experience with sex. Behaviors. So an example of this is, avoidance of intimacy or physical closeness because of, worries about pain, for example, with sex. Thoughts are another component. So negative beliefs about like one's self or one's body can come up. In the physical domain, this can look like pain or hormonal changes that might be occurring. Feelings, examples of this might be like stress or anxiety that emerge for people. And then in terms of relationship dynamics, things like communication challenges or mismatched types of desire are just a couple of examples. So lots can really go into someone's sexual experience. Next slide, please. So myth busted here. Sex can be complicated. Another myth that I want to move us to. I'm the oddball because sex is just not the same since I've been going through menopause. What we know is that across a variety of different sexual experiences, people can have a variety of changes that occur during menopause. And so what I want to do first is highlight what are the kind of common experiences people have during sex, and then how can menopause affect these areas? So sex really often involves kind of four main experiences, and these are definitely not linear. People can kind of move back and forth between these experiences in the context of sexual activity, but I want to highlight each of these. So the first is called desire or interest, or you might have heard, in medical terminology, like libido is what this is referred to. And this is where you feel interest, attraction, or mental readiness for sexual activity, which can be triggered by thoughts, feelings, physical attraction, or closeness with someone. Excitement or arousal is another experience, and this is when the physical signs of arousal can really begin. So, for people with vulvas, this can mean like, increased vaginal lubrication, swelling of the clitoris as more blood flow goes to the genital region. Heart rate and blood pressure might also increase. And emotionally, there can kind of be a sense of anticipation that occurs. Another primary experience during sex is orgasm or pleasure. And you see I have a little star there because we define this broadly, and orgasm is not always the goal, nor should it be necessarily. Dr. Shelby will talk in just a bit about some different kinds of reasons that people might experience pleasure in the context of sexual activity. And then the last phase that I want to highlight is resolution. So this is really where the body just kind of comes back to its resting state after sexual activity. So, sorry, there are a few animations here if you want to click through them. So in the context of each of these areas, there really can be changes secondary to menopause. So with desire and interest, we see changes like increased or decreased experience of desire. There might also be co-occurring physical or mood changes that impact desire. In the kind of experience of excitement or arousal, we might have vaginal dryness, which I know Lisa talked about just a bit ago, and potentially reduced sensitivity in the genital region, which can impact what is needed to experience arousal. In the orgasm or pleasure category, this can look like fewer or less intense orgasms or changes in what's needed to experience pleasure. And then in the resolution phase, this could look like kind of a faster return to baseline or a longer refractory period. And refractory period is kind of just a fancy way of saying the amount of time that passes before someone's interested in sex again. So another myth busted here. The next one I want to highlight is actually a couple here. I don't feel interested in sex anymore. Something's wrong with me. And women aren't interested in sex as they get older. we know that both of these things are false. And what's really helpful here is to try to understand a little bit about where there might be differences in sexual desire that are normal. So, sorry, a couple more animations here. um, the first that I want to refer to, the first type of desire is called spontaneous desire. And so this is when you feel interested in sex kind of out of the blue without anything specific triggering it. So this is kind of characterized by like hormones, having a new partner, or novelty in sexual experience. Whereas receptive desire is another type of desire in which interest builds really after you're already kind of being affectionate or close with someone. It occurs in response to the moment. So this is more kind of akin to like emotional connection, feeling attractive, and acceptance of oneself and one's partner. So another myth busted here. The next thing that I want to highlight is another myth here. When my partner comes to me already aroused and ready to kiss, I'm kind of getting the ick. Something must be wrong with me, or I don't like my partner anymore. So this brings me to wanting to kind of highlight that there are differences in how people build sexual arousal. And at any point in time, there's kind of a balance between what I call on the gas pedal, or kind of the turn ons for someone, versus on the brake pedal or on the turn offs for someone. So I've got some just kind of brief examples of this here. But on the turn ons might be things like emotional closeness, confidence in oneself, seeing sexual imagery that's interesting or appealing. And then on the turn off side of things, this might be like difficulties with mood or anxiety, or challenges in the relationship that are present, hot flash symptoms, or other symptoms that you might be experiencing, just to name a few. So another myth busted here. Rebecca, I think I hand things over to you here.
Well, hi, I'm Rebecca Shelby. I'm also a clinical psychologist and a part of the sexual health and intimacy program in Duke's Cancer Center. And so I see patients for sex therapy after cancer treatment. And like Juliann, along with Lisa, do research into sexual health and sexuality and intimacy. So I'm going to pick up. So Juliann has talked about interest and desire and arousal, and I'll pick up with talking about orgasm and pleasure. And for that conversation, we really do need to talk about the clitoris. So instead of sharing some anatomical diagram, what you see there is a sculpture of the clitoris, known as the glitteris. It's by a artist from Australia. You can see her there. But that is an image of the clitoris and the clitoral bundle. And this is really the source of pleasure and sensation for females. And you can see the top there is the clitoral glands, and that's usually what we think about when we think about the clitoris. It's at the top of the vulva, it's what's accessible externally. And that's usually what we think about, but it's a much larger bundle, right, or organ than that. And its sole purpose is for pleasure. It's the only thing in the male or female body that's sole purpose is for pleasure. It has lots and lots of nerves. It's very sensitive. It connects to many more nerves throughout the pelvic region. And what happens is you can see that there's the glands, but from that there's a shaft, and then it has sort of legs that extend around the vagina with those two components that sit sort of near the entry of the vagina. And the clitoral bundle can be accessed through the vaginal wall sometimes. So if you hear people talk about the G-spot, or people trying to figure out, does that exist? What they're really talking about is accessing the bundle of nerves, the clitoral bundle, through the vaginal wall. It's also tissue that becomes engorged with blood. So as arousal increases and blood flow increases to the pelvic region, the tissue in the clitoral bundle also becomes engorged, increasing, right, sensitivity. So I think it's important for us to sort of think about and understand the clitoris, and that there are changes, important changes that happen with menopause. So as circulating hormones decrease after menopause, the clitoris can become smaller over time. It does not disappear. You see Google searches about that. Does it disappear? It does not disappear, but it does become smaller. Sensation also can change. So some women will describe it feeling less sensitive, or sensation feels blunted. I've had people I work with describe it as it feels like there's a wet blanket over everything. So changes in that way. And also changes in blood flow. And so it may be that you will need more or different kinds of stimulation to get the same sensation or blood flow. And that we'll talk about in a minute, that after we sort of plateau, or we start to reach resolution, sort of blood leaves the pelvic region much more quickly. And so all of that to say that part of this means that we have to sort of change some approaches usually as we go through menopause and postmenopause. So for example, you might need much more direct clitoral stimulation or more intense stimulation to get the same level of sensation or build arousal than you did 20 years ago, right? Or before menopause. And so I think work with a sex therapist, or I think, Lisa, some of the work you do with folks around figuring out sort of how do we get that kind of stimulation while also not increasing the risk of something like UTIs, or now sort of causing some tissue discomfort or damage because it's more sort of more sensitive tissue. So a lot of times that's where we're thinking about different approaches like clitoral stimulators or vibrators or other approaches to activity. When we're talking about orgasm, we're usually thinking about sensual pleasure, so the sort of physical pleasure. So one myth is that we want to think about is sensual pleasure is the only kind of pleasure that is experienced during sex. We go to the next slide, please. Yeah. So certainly sensual pleasure, that's usually what we think about and talk about and see in the movies, right? Or when we think about sex. So the physical changes that happen with sensual stimulation, this physical sort of sensations of arousal and orgasm. But that is just one component of pleasure that humans derive from sexual intimacy and sexual activity. And you can see sort of there's a number of different kinds of pleasure up here, some that are part of partnered activity, some that apply to both partnered and unpartnered activity. And so when we think about the experience of pleasure during sex or sexual activity, it is really multifaceted and it's very rich. There are many reasons why people seek out or want to have sexual intimacy or sexual activity. Part of it can be bonding pleasure, so that experience of closeness or affection or intimacy or safety with another person, right? So bonding pleasure can be a part of it. Interaction enjoyment, it's a little different than the bonding pleasure. It's more about a shared experience. You can think about sexual experiences where both people are really engaged and sort of creating that positive feedback loop. And that's that interaction enjoyment sort of facet of pleasure. I think the last one there, we don't really, I think, talk about a whole lot or think about, but these are also really important. So pleasure-related mastery has to do with our feelings of sort of agency and ability to create pleasurable sexual experiences for ourselves and for others, right? And from that, there can be a lot of enjoyment or pleasure through that experience. And certainly through sex and sexual pleasure and intimacy are ways that we also can connect with our feelings of worth, of value, of meaning, and it can help people really connect in that way. So there's a whole sort of range of sources of pleasure that come through sex and sexual intimacy. All right, we can go to the next slide. Yeah, so that's busted, right? That typically when people are talking about sex and sexual pleasure, they are thinking orgasm, but it's to understand it's much broader and much richer than that. And that we really want to think about that in terms of what we're building in terms of our sexual experiences. All right, so we can go to the next slide. All right, so the last sort of experience that we'll talk about is resolution. And as Juliann mentioned, that is when the body comes back to its resting state, comes back to baseline after experiencing sexual activity or arousal. With menopause, one of the changes that happens is just as it can take longer for arousal to build, we can return to baseline much, much quicker. So after menopause, the blood flow that sort of went to the pelvic region leaves much more rapidly. And that there also may be sort of Juliann mentioned that longer refractory period where it may be a longer period of time before being interested in sex again. And I think this is important to understand, especially around the quicker return to baseline. As Lisa mentioned, that for a lot of people who she works with that have been in long-term relationships, everybody sort of has their routine, right? Or their sexual script or the way that they go about it. And sometimes that's where we can run into trouble. So for example, it's not uncommon, I might be working with someone who their sort of sexual pattern has been that they would first reach orgasm through manual stimulation, and then they would go on to penetrative activity or intercourse. And what they're finding is now intercourse is starting to become uncomfortable or painful. And what could be happening there is once they reach orgasm, their body is now much more quickly returning to baseline. And when they move into intercourse or penetrative activity, right, they're no longer aroused. And their tissue has sort of become drier and there's less blood flow and so sex is becoming uncomfortable or painful. And so understanding that can help us sort of figure out, like, we just need to sort of maybe change up the order of things or approach it a little bit differently. All right, so Juliann, I'll hand it back to you.
Sounds good. So we want to transition now into talking a little bit more about some tips and strategies that might be useful to address challenges that might be coming up with sexual wellness in the context of menopause. So we, highlighted earlier that sex can be complicated because there are many different factors that can be at play that can impact someone's sexual experience. So at a high level, kind of what we want to talk about here are some tips related to identifying what might be on the brake pedal for you that could be really interfering with your ability to build arousal. We'll also talk about some strategies to build openness to intimacy, touch, and sexual activity broadly. And then we'll also talk about some tips to kind of gradually approach intimacy with your partner in a way that works well for you. So I think one of the most helpful things to consider is really asking yourself, what is on the brakes for me? What is on the brakes that might be impacting my ability to build arousal for sexual activity? So you can ask yourself some questions like, how am I feeling physically? What's going on for me emotionally? What thoughts are coming up for me? Are there thoughts coming up around like how my body looks? For example, am I feeling anxious about having pain in the context of sexual activity? Are there relationship dynamics at play that might need to be addressed? Like, is there resentment because your partner didn't do something that you asked them to do earlier in the week, or are there other kind of things that need to be communicated that might be on the brake pedal with regard to your partner? Are there other stressors at play? Just is life kind of busy? Are there lots of things kind of going on for you that might be impacting or sitting on the brakes for you to be able to build arousal? So, one tip to kind of think about if you are noticing that what you're thinking or feeling might be something on the brakes for you. So, let's say, you're noticing more, you're feeling more anxious or you're feeling more down. What are some things that you can do here? One tip is to begin a mindfulness practice that can actually help you to build some openness and awareness of thoughts and feelings that might be present for you that are just not super helpful. There are many different ways to practice mindfulness, and there are some fantastic apps that you can download to give you a variety of mindfulness practices. Calm is an example of one of those. But really, mindfulness at its core is a skill of really kind of building awareness in the present moment with curiosity and without judgment. So this is a practice that can help to just build some awareness of what's present. Another tip related to this is during sexual intimacy, if you're finding yourself kind of like, in your head a lot or noticing an unhelpful thought or feeling, to acknowledge what has kind of distracted you and then find some kind of sensory experience to cue into. So this could be like skin to skin contact, the warmth or pressure that you're feeling from your partner's touch. It could be cueing into breathing, textures that you're noticing as well, or even things like the sound of your partner's voice. So a variety of things you could kind of cue into to bring yourself back to the present. And then a final tip is to look for some opportunities to replace unhelpful thoughts or feelings with helpful self-talk, so helpful thoughts. So some examples of this might look like saying to yourself, it's okay to take my time. I don't have to be perfect. This is about connection, not performance. I deserve to feel good and enjoy this. My body's allowed to respond in its own way, and I can focus on what feels good right now. So just a few kind of ideas of increasing this helpful self-talk. If you notice for yourself that sexual pain is on the brake pedal, then there are a variety of things that you could do to perhaps get some support around this. So one thing is to, think about bringing this up with your healthcare team and chat with them about options that might help to address sexual pain. So get the right, exams completed, referrals, treatments that they might recommend. As Lisa described earlier, perhaps part of that might be getting some vaginal moisturizing on board and then lubricants in the context of sexual activity. You might benefit from a referral to pelvic or women's health PT to get some support around pain. There also are some behavioral strategies for managing pain, which might include like really focusing on the positions that are being used, allowing yourself time for like stretching and kind of approaching sex gradually, and then given enough time for you to build appropriate arousal. So one of the things that we often hear for people, because how arousal builds might change in the context of menopause, is that they might need more time or different kinds of activities to build that arousal so that sex isn't painful. And then you also could connect with a counselor who has experience in supporting folks to manage pain. So just to kind of get even more support and tips on board to help with navigating that.
Okay.
All right.
Yeah. So thank you, Juliann. And I think identifying what's on the brake pedal and figuring out what to do with that is often, I think, a lot of the work that's happening in sex therapy or as people are navigating sexual changes or problems. The other piece is around building openness. And so Juliann shared with us the different kinds of desire that people experience. And so certainly there's, right, the spontaneous desire that is much more, I think people will sort of say, I have all this tension and I want to release. That might be a description of spontaneous desire. Responsive desire works a little bit differently. And as Juliann mentioned, it's something that sort of happens once we engage with something sexual. So it's a little different, right? That we engage with something and then the desire, right, starts to build. So when I get sort of most frequent referral that I get is around loss of interest or desire. Often what I'm talking about with folks is not necessarily like, oh, let's get you interested, but it's taking kind of a step before that to say that we really first need to build openness, right? Openness is sort of the building block or key ingredient we need. Openness to interacting with something sexual, to touch or being touched. Right, that's sort of the thing we need before you can do the things that would help responsive desire unfold. Right, so often instead of working on building interest, right, we're building openness and thinking about what that means. One important piece to think about is, like I said, often I think in popular culture, we sort of talk about sex as a drive and it's sort of this tension reduction model idea. But really, sex is a reward-based system, right? Sex, when we think about those rewards that we talked about, all of those different sources of pleasure, from the sensual to the bonding, the interaction, the mastery, these are all rewards that we anticipate and that we experience during sex. And when you think about sort of sex and how much sort of desire there is, you have to think about there has to be liking to be wanting, right? So for us to want to seek out something and want something, there has to be some reward or liking or things that are valuable in it for us. And so one thing that I'll often start to talk about with people is, well, what is there for you to like in your sexual activity, right? And in your sexual experiences? And have they sort of honed in just on sensual pleasure and that's not going well, or it's challenging? And sort of how can we expand that again to really think about all of the sources of pleasure and rewards and what there is to like? And so liking will lead to wanting. And so it's thinking about, how do we create that in terms of building openness and interest? The next slide, please. Another piece of this is connecting with our sexuality is really, really important. And I think in order for openness to build and for us to sort of have experiences of responsive desire, we have to connect with the sexual part of ourselves, and we have to engage with sexual sort of thought or fantasy or content, as well as experiencing touch. And often you can think about the way we shut down that part of ourselves or do not connect with sexual things. Sometimes it's a brake pedal kind of thing. Sometimes I'll hear people talk about, well, a sex scene comes on TV and I think, oh my gosh, like, why do I need to see this? And I leave the room. Right? Or we talk ourselves out of it, right? I was interested and then I sort of talked myself out of it. So when thinking about connecting with your sexuality, is thinking about doing things that will help connect with that and build openness. Some of this can be doing things to help you either feel confident or desirable or sexual. And I think that's really different for everyone. I think it's thinking about for yourself what that is. For some people, it might be physical movement. For some people, it is self-care. It's, is their skin soft? Are they using lotion? For some people, it's, what kind of underwear they choose to wear. So you can think about what helps you connect with sexuality and that sexual part of yourself. The other piece is having sexual thought or fantasy or sexual experiences in terms of engaging with sexual content. And I think it's really, again, thinking about everybody's different. What is a good fit for you? For some people, when we talk about this, they'll tell me, well, I have sort of, for me, it's my memories or sort of a highlights reel, right, that I think about. For some people, they'll say, I really like romantic kind of movies where there's connection and there's caring and like that really is exciting to me or what sort of helps me connect. Other people will say, yeah, I just really, for me, sort of hot scenes and movies do it, right? So I think it's thinking about what helps you connect and build that openness. And then also thinking about physical touch or affectionate touch. And so I think what can happen is if physical touch or affectionate touch is only happening as part of sex or a prelude to sex, that people often start to sort of lose that as part of the fabric of their relationship. And so it can be really difficult if you're both sort of living in your separate corners, right? Then to all of a sudden, if you want to be sexual, have this very intense, right, physical connection where it requires being very vulnerable. And so we think about how do we get physical or affectionate touch, right, as part of the relationship that isn't just tied to sex, right? So that's sort of a building block of openness. And then also exploring self-touch, connecting with your body, understanding where you have sensation, how your body, what works well, what doesn't. And that can be another way to connect with sexuality and build openness. Yeah. And that brings up also reconnecting with our bodies. It is very easy to get disconnected As people have changes in their bodies with menopause, you can think about other changes that you may have experienced in your life, whether that be medical procedures or health changes, pregnancy, childbirth, being a parent, right? All these things that we experience throughout our lives really get us disconnected from our bodies. And a key piece of sex and sexual pleasure is really being able to be present in your body. And so thinking about if you are disconnected from your body or parts of your body, how to reconnect with that. Is that, something that is around like sort of self-talk and sort of what you're saying to yourself about your body. I think touch can be very important. I talk to lots of people who, we talk about, well, when you shower and afterward, if you're taking care of your body, are there parts of your body you avoid? Or don't touch or don't care for, and how do we get reconnected with those parts of our body? So that can be another place of building openness as well. Yeah, and we'll sort of move through these because I know I want to make sure we have time for questions. But as Juliann mentioned, that communication is often a big challenge, a big piece on the brake pedal often, and communication is essential. And we just, I think, as a society and as a culture, we're not good at this. We're not good at talking openly about sex, even with our sexual partners, even with our long-term sexual partners, and even in relationships that are going well. It's a challenge. It's really, really difficult. But in thinking about communication is so important in the sense of being able to talk about experiences and talk about expectations and really open up those conversations. So one thing I think to think about is you can also do this in small bite-sized pieces. It doesn't have to be a huge, like, sit down heart to heart, right? They can be in small bite-sized pizzas as you start to open up these conversations. It's also thinking about what kind of conversation you want to have. Some are problem-solving conversations where there's a thing we want to figure out how to solve and fix, and we want to do that. And some are more sharing thoughts and feelings. And so thinking about what is the goal of your conversation and letting the other person know that can really shape to make sure you're both on the same page. Because I feel like nothing goes off the rails more than a conversation where one person just wants to share how they're feeling and the other person is offering like, but you should just do this, right? So not so helpful. But think about what kind of conversation you want to have. And you can see there's sort of the thing we typically hear, right? Using I statements and using more descriptive language. And so, for example, being able to say something like, I have noticed things are different for me now and I need more time. I'm finding I don't have enough time to get excited before we have sex. And I feel like I need to slow things down, right? That's a very descriptive, right, thing. So thinking about being sort of descriptive, using I statements, being sort of specific and asking open-ended questions, right? How is it for you? What are you experiencing? And trying to just do it in these small bite-sized pieces, I think, can start to open up that conversation. And certainly it is common that people often need help with these conversations. And that's certainly what folks like Juliann and myself and others are here for, to help sort of open up those conversations, because it can be really challenging. And the last piece we'll talk about here is restarting or building sexual intimacy, or starting intimacy for the first time can also be a part of this. But really thinking about what do we need in terms of building openness and then easing into sexual intimacy, right? Sometimes it needs to be sort of a slower process. Something to think about, building connection and having positive experiences are extremely important, not just sexual experiences, but more broadly. There's some data from, I think it's the Gottman Institute, who has data on like 60,000 couples over 20 years. And for couples who are reporting high levels of satisfaction and well-being, one of the sort of common things, one of the threads, is that they report having new and positive experiences together. So that can be very simple things like you both like nature, so you go for a hike together, right? but it's building connection, and positive experiences are important. When you think about intimacy, starting slow and beginning with what's comfortable. And again, that's going to take communication, right, to set those expectations. But being able to say is something like, I don't know if I'm ready for intercourse or sex. I would like to be close. Maybe kiss, maybe oral activity is part of the mix. So it's thinking about what you're comfortable with and where you'd like to begin. Another piece of this, the sort of keeping pressure low, I think Juliann started to reference this a little bit, to say that mindfulness piece of focusing on the experience of kind of what's happening in the moment as opposed to the outcome. And when we think about pressure, that's often when we kind of get in that space of a very outcome focus of, is orgasm going to happen? How long is this going to take? Is this going to hurt? Is the other person going to like it? Right? That all those pressures we place on ourselves, and to try to sort of pick activities that are going to keep the pressure low and allow you to be focused in the moment and what you're experiencing. And as Juliann sort of mentioned, when all those thoughts start to come in or pressure starts to increase, we can cue into something like a physical sensation or a sensation to sort of help pull us into the moment. And the last piece here, the last couple pieces, is one around setting aside time, of really planning and setting aside time for sexual intimacy. And I have a lot of people say, I don't want to schedule. I want to be spontaneous. Scheduling feels weird. And what I sort of try to describe to people is you want to set aside time for opportunity. Right? It doesn't necessarily mean that you need to perform, right? We don't want that kind of pressure, but set aside time for opportunity, where it's not going to be rushed, where you're not going to be overly tired, where there aren't a bunch of competing demands, so that you can be in the moment and create space, right, for this. And the last piece is that just making sure to sort of take off the table any activities that will cause sexual pain. We don't want to pair sex and pain together. I think the more that we do that, then the more we start to develop problems like anticipatory pain, and it becomes our body has a response to that. And so often as people are working with somebody like Lisa or coming up with other strategies to manage sexual pain, we'll sort of talk about taking activities that cause pain off the table in the meantime. All right. Juliann, I think you have some resources for us, right?
Yeah, sure. So lots of different resources here to consider and explore. Just to highlight a few, Come As You Are and Come Together are great works by Emily Nagoski, who is an expert in sexual health. Vanessa and Xander, if you're on Instagram, this is a couple. Vanessa is a sex therapist and Xander is her partner, and they wrote the book Sex Talks, which you'll see above. This is a really kind of interesting book that just gives some ideas about conversations to have with your partner that might increase your sort of understanding of each other and your interests related to sexual health. And then also a number of podcasts that you could check out as well. I think these are just some references. Yeah.
Great. Thank you all so much. This was super helpful, and I actually learned a lot today too. So I'm feeling really good about the content that you shared with all of our attendees today. I also want to let you all know that we have a study going on and that we're recruiting for right now. And I've shown this slide before in past seminars, but we are still looking for people, so if you think you might be at all interested in trying a research study, please either give us a call or take a look at our website there. And we will, if it's okay with the folks here, we'll send out those resources on that slide to everybody. So you'll get that and any like other links that might be helpful. This is a new opportunity. If you have teenage kids at home, this is a study for you. So there's a QR code here. It looks a little fuzzy, but hopefully that still works. And like I said, we'll send out this link so you don't have to write it down. Okay, just as a reminder, we do have a menopause clinic in OBGYN here at UNC, and as well as in psychiatry, where we offer therapy as well as other sorts of short-term interventions for menopause-related symptoms. All right, so now the fun part where we take questions.